And welcome to the Dr. Bob Show. We're going to be spending most of this show talking about the hands. Sometimes we take the hands for granted. We grab things. We can actually talk with our hands, or we can do sign language with our hands, grab things, squeeze things, pick up things. But things can go wrong with the hands. And we're going to be spending most of this show talking about what can go wrong, how we can prevent that, so that we won't get orthopedic injuries to the hand. My guest is Dr. Tim Renfree. Dr. Renfree is a board-certified orthopedic surgeon who deals with the hand and the wrist every day. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about psoriasis. Is there new treatments for psoriasis? How common is it? Is it contagious? And we'll be talking about the heartbeat. How do we know if the heart is beating properly, and what does it do when it throws blood out to the rest of the body? A lot of information for you. You'll want to stay tuned. We're talking with Dr. Tim Renfree, board-certified orthopedic surgeon, deals with the hands, wrists, elbows. Tim, welcome to the Dr. Bob Show.
Thank you for having me.
When I think of the hand, are there common hand injuries such as, for instance, laceration? What happens if somebody has a cut in the hand?
Very, very good question as far as difference in the laceration. Lacerations in the front side would involve the flexor tendon, so that's what bends the fingers. So very strong tendons. Those actually are injuries we have to get into the office and taken care of if they're completely cut within 5 to 7 days. If you don't get on them within 5 to 7 days, they're almost irreparable.
Does a person know if they've severed a tendon? You know, you've got a cut and it's bleeding, and do they know their hand is not working well?
Yeah, that's a great question. They got to go to the ER, obviously, and want to make sure they're up to date on the tetanus. Nerve and vessel injury, so if they're very insensate past the cut, they might have got the digital nerve that sits right there. That's repairable, obviously. But the key is once we get the bleeding stopped and everything settled down, and they may put a few stitches in, once the patient's more relaxed, trying to get them to actively flex their fingertips. And as long as you can get that fingertip bending on your own, so actively bending it, the tendon's probably okay, and that's generally the emergency room doctor will make the call there and say, wow, we really can't get you to bend your finger. We need to get on the phone, get you over to see a hand surgeon. We got to get that fixed.
So that's got a 5 to 7 day, you better get it fixed quick.
You got to get it quick.
You're not going to get it fixed.
Correct.
How about the back side of the hand, the extensor?
The extensor surface, you got a little more time because it's not under as much tension, so it's held more in check. So if you cut an extensor tendon, they will retract a little bit, but not far enough where you have that 5 to 7 day. You still want to get on everything early, but you got a few more days there that it's not as much of a rush.
What do you mean by retraction? If somebody lacerates a tendon either on the flexor or the extensor, what does retraction mean?
So when you cut the flexor tendon, if it pulls back in, so there's really actually two tendons that are responsible for bending the finger. You've got the deep one, the profundus tendon, and that bends the tip, and then the superficialis helps, and that bends the knuckle here, and that's really more for helping with power. Those will retract actually all the way into the palm, and unless you splint that patient in the emergency room, not just putting a metal splint on, but really putting the splint and blocking out the wrist, the more they move their wrist, the more that's going to pull that tendon back into the forearm, because basically the muscle is under tension all the time. It wants to shorten. It will pull that tendon all the way back down. And that's really the problem. You can't get it back out to length. If you try to pull it out to length and the muscle is already contracted, then the patient will have a bent finger and it'll create other problems. So you just can't pull it out to length.
Can you pull it out to length in the operating room? Can
Yes.
you grab it and pull it out?
You can. So if you get in that window where the tendon and the muscle hasn't retracted and scarred down too much, you get it out to length, and then it's really just sewing them back together. We would teach the residents to learn how to sew these. We would get those rubber worms that you fish with.
Yeah.
So you would teach them with that, basically you cut it in half and then just kind of feed sutures inside. And it's really kind of like you're just locking these internal stitches in the tendon and then sewing them down and pulling it together, and then you repair over the top with some smaller suture and kind of make a nice easy pathway for the tendon to glide.
So when you sew up a tendon that's been completely torn and you fix it, you sew it up like you sew one of the plastic worms,
right?
And you get it taken care of. What's the recovery time?
So what you have to bend the fingers is they run through a series of tunnels, so called pulleys. So as long as the pulleys are intact, we want to get them moving very quickly. Good studies have shown that the better the repair, so if you've got more strands inside the tendon, the quicker you can get them moving. Because my goal is I want a full fist. The longer you wait on that motion, the more chance you have of it scarring to those pulleys and then patients getting stuck. Similarly, too aggressive, and it can break.
So you have to pick a magic time on how much to do and how little to do to get the action going?
Right. So your worry point is from the point you get them fixed, roughly a couple days after, to about 28 days after you fix them, before you can really be pretty risk-free of trying to make a fist and pop it. About 6 weeks after you repair them, you start strengthening. By about that 9-week mark, you're really out there doing what you want to do.
The tendon's easier to heal on the extensor surface or on the flexor surface?
More reliably, the extensor surface it's just easier to fix. The extensor surface, though, is more intricate. There's a lot more things going on. Just to extend your finger, there's different sets of tendons. One's called an intrinsic set, which is inside the muscles in the hand, and the extrinsic, the ones that come from the forearm. So the flexor surface really only has those main flexor tendons, bringing them down, but the backside is more involved with your intrinsic. So if you cut the tendon here and you repair it, you can get those moving pretty quickly and having good glide, and they tend not to stick down because there's no pulleys.
What circumstances do you find that the flexor tendons or the extensor tendons are injured? Any type of sport activity where they're injured?
Like I said, it always seems like we go with the sports. So fall is football season, it's volleyball season, and lacrosse. So by far and away for football is they call it jersey finger. That's where patients will reach out to grab the jersey and they'll pop that tendon off. So instead of it cutting it, they actually pull it away from the bone, and that will retract. Similarly, it has to be fixed pretty quickly.
What about baseball season, other times of the year?
Baseball season, commonly what we'll see more fractures and little league stuff. So for some reason, the thumb gets beat up in baseball season, whether that's catching a ball or a hop or catching one on the thumb. And basically in a boy or girl that's not yet reached skeletal maturity, there's still growth plates. Those aren't strains and sprains. Those are fractures by far and away. Where there's really a skier's thumb, where patients always talk about gamekeepers, that's more of a ligament injury in an adult. A younger person will tend to pull that bone off, so it's an avulsion injury, a true fracture. Whereas older people, old people like me, will actually tear the tendon and get a gamekeeper's thumb.
If somebody hurts their tendons, hurts their fingers, hurts their hand, what's the biggest mistake that a person makes of not recognizing something's going on?
Not getting in. I think that you'll often see, and we all do it.
Sure.
They'll just put a splint on there and just think they stoved it up. Generally, that's a ligament sprain. Well, a ligament sprain means a tear in the ligament. The only question is, how severe is it? If there's instability associated with it, like at this knuckle, it's very common to hyperextend it. Patients say that the trainer or someone put it back into place. There's actually a tear there that we need to judge and see if it's unstable. We need to protect it and buddy tape it, and sometimes even place a blocking splint on the back. It allows them for full motion, but then we'll slowly bring it up about 10 degrees a week to make sure that they get all their motion back. So just locking a knuckle down or a finger down can create a lot more problems down the line because it gets really tight, and then you gotta work in therapy to get it free.
So the best thing if you've got a hand injury of any kind is to be sure that it's checked out properly so that you get the proper kind of treatment.
Sure.
Are there other problems in the hand that are common, like ganglion cysts, like Dubitron contractures, like
Lumps and bumps.
Lumps and bumps in the hands.
I love lumps and bumps.
And that's what we're going to be talking about when we come back. I love lumps and bumps in the hands. We'll talk about what the lumps and bumps are and what needs fixing and what doesn't. A lot of information. You want to stay tuned. We're talking with Dr. Tim Renfree, board-certified orthopedic surgeon. We've been talking about the hands and the wrists and the elbows. We've been talking about tendon tears, both on the palmar surface and on the extensor surface of the hands. It's important if you've got a tear of a tendon that you get it taken care of quickly. If you've got some injury, be sure that it's evaluated properly, because early treatment may be the difference between having good results and not. Tim, let's talk about what goes wrong with the thumb. Is it the base of the thumb or the top of the thumb? When you say thumb injuries, what are you talking about?
Two of the most common things, trigger thumbs. So any trigger finger is soreness in through here. And patients will come in, either it's triggering and locking and catching on them, or just by gripping and grasping, which is how it's pretty much caused. They're getting a lot of pain. That's an easy fix. And
How's it an easy fix? What do you do?
I don't like medicine, and I don't like shots, but that is the one thing I've had myself. I ended up having someone give me a shot, gone. So you can get rid of that with a simple shot. CMC arthritis is probably the second most common thing I see in the thumb.
You say CMC arthritis, what are you talking about?
So yeah, the carpal, which is the wrist bones, metacarpal, the thumb bone, or the bones in the hand. That joint right there, 1 out of 4 women have an arthritic problem with that.
Why do they have that?
Some guess it might be just ligamentous laxity. They're more ligamenously lax, or their joints move a little easier than ours.
And what problem occurs?
So the joint is basically 2 saddles facing yourself. So unlike any other joint in the hand, this joint actually has 3 planes of motion. So it's got a lot of chance to slide around. It's also in charge of pinch. So in order to have a firm pinch or grasp, this has to be stable. So over time, that can slide around, and if you're more ligamenously lax, it gives it a little bit more leeway, and it'll start to rub incorrectly, rub the cartilage off, which is arthritis. So arth means a joint, itis, inflammation. Rub that soft surface off, or that bearing, the joint surface. It'll start to get to bone on bone. The bone sees the increased friction and stress. It creates bone spurs, because that's just the bone trying to create more support, and that's where they get the cracking and the soreness.
What do you do for it?
First time, just make sure that what we have is arthritis, so I'll take an x-ray. Oftentimes, I'll get them started in a tether brace. There's different types. My thought on this is, the more rigid the brace, the less frequent the patient will wear it. So we try and find a brace that is going to work best with the patient and their activities. Let's face it, people are active. They want to keep using their hands, or they wouldn't come see me. If it needs a shot, I'll put a cortisone shot in there. It'll settle it down. That's not a fix. But good literature supports 54% of the time. Just good activity modification, a good splint, and some injections here and there will stave off any type of surgery. But to be honest, the reason I went into hand surgery was this surgery. I love it. When I was in residency, patients feel like it gives them their life back.
So what do you do in the surgery? What do you do?
Been written up all different ways. I have my way that I learned in my own fellowship. But the bare bones of it is there's an incision over the thumb. You remove the arthritic bone, and I know that sounds odd, but that is the arthroplasty part. Arthroplasty just means changing the joint surface. So I remove that bone, and then I'll reconstruct the ligament that's stretched out, and that's called a suspensionplasty. And I use a spare part from the patient, so there's no metal or plastic. Because I think if you look at how hand surgeons have done this over years, and you look at hand surgeons in general, we like to use the patient's tendon to reconstruct the ligament and not put anything in there, because it's a really complex joint and they tend to wear out. So
what kind of results do you get with that?
Excellent. It's actually a great surgery. The patients have about 5 weeks in a cast, and that's really the downside. Then we get them moving in therapy. Generally, they're doing most of it on their own. By 10 weeks, I want them strengthening. By the 4-month mark, they're back to playing golf and normal activities. So it's a great surgery. It is a bit of a downtime. It's not a quickie like a carpal tunnel release or a trigger finger release where you're moving immediately. But it truly does give you back your activities.
When we talk about joint replacement, we frequently think of knee joint replacement and hip joint replacement. Can you replace some joints in the fingers? Tell me about it.
You can. So traditionally, a doctor named Swanson, way back when in Michigan, came up with putting in silicone implants. Great, they're perfect, they do really good for pain relief. However, they have been shown, Mayo Clinic had a great study. They only give you, anywhere from 5 to 10 years of longevity, and then they'll start to break. So there have been implants created for these joints specifically, and in the knuckles here, that will give you a little more longevity. In fact, a lot more longevity. And some of them are made of pyrocarbonate, and some of them do have a plastic, basically insert inside. Mm-hmm. What that allows you to do is actually start motion a lot sooner, but only certain patients, ones that don't have gross instability or a lot of deformity, those patients aren't good candidates for that. They'll end up getting unstable. But for a patient that remains active and just has true degenerative arthritis, they're fantastic.
That's fabulous. Ganglion cyst. What's a ganglion cyst? What do you do for it?
Ganglion cyst is basically a pocket of fluid that comes from a joint or fluid-producing area. The flexors can produce fluid, and that's called a retinacular cyst. The knuckles can produce fluid. Generally in the fingers, it's called a mucus cyst. And so any bumps or lumps. In the wrist, they tend to call them ganglion cysts. So we're hand surgeons, we're geeks. We like to give everything different names. But regardless, we like to go in, and if they're in the wrist, sometimes you can try and aspirate them, but largely we'll just make a small incision and remove them, because they tend to want to come back unless you can remove. It's like a weed. You got to remove the stalk out of that joint. So you just remove them, a couple of stitches, and get moving.
Good results?
Yes.
Carpal tunnel syndrome. Spend just a little time talking about carpal tunnel, how it bothers people. What is it really? Yeah. How does it bother people, and what should be done?
By far and away the most common thing I see. Most common surgery in America is carpal tunnel release.
Wow.
They say 10% have carpal tunnel syndrome. It's multifactorial, meaning it's probably a little bit genetic, could have a little bit of a metabolic or an endocrine predisposition, such as patients with diabetes. But what it is the median nerve, as it runs down the forearm, enters the carpal tunnel. So that's a wall of basically 3 bones, or sorry, the wall is encompassed of bones, and then a rooftop of a ligament called the transverse carpal ligament. That's a very thick structure. You cannot stretch it, you can't move it, it's very thick.
And everything goes under it.
9 tendons, the strong tendons that flex the fingers, they run through there, and one nerve, the median nerve, sits on the very top. So those tendons, if they swell or collect water, they're going to take up the space. So it's a fight for space. The nerve's going to lose, because it's obviously the most delicate flower in this whole mix. So it's basically cutting off the blood flow to that nerve. Like if you fall asleep on your leg and your foot goes to sleep, you get up and you stomp your foot, it's asleep, and then it slowly gets that nerve sensation, that sensation back. Those pins and needles, though, that you feel as it's waking up, that's what a patient with carpal tunnel feels all the time, because no matter what they do,
they can't
shake that out.
So what do you do for it?
We'll start with a brace at night. So oftentimes people will sleep with their wrist flexed. They're pinching the nerve. You straighten the wrist, get the blood flowing through it at night, and it helps. If it no longer gives you benefit, you can try a cortisone shot. The thing I have with a cortisone shot, and again, good studies have shown, you probably don't have good efficacy or long-standing. Maybe at a year's time, 90% return. If it's really significant, patients are having lots of problems, starting to get any atrophy or constant numbness and tingling, I recommend just a release, just making a small incision in the palm, releasing or dividing the ligament. We don't need the ligament. Everyone asks me why we have it. I don't know.
It's there.
But there's no functional need. So you release it, a couple of stitches, moving right away.
Can there be damage done before you release it that doesn't come back, or does it always come back?
Excellent. So when patients come in, the main thing my job is I'm trying to keep this nerve as functional as possible. So if I start to see an area that maybe you're losing some muscle here in the thenar, or the numbness and tingling is more constant, yeah, those nerve fibers don't come back. So if you've already lost those wires, because it's like a coaxial cable with millions and millions of wires, if part of that coaxial cable has been damaged, we're not going to get that back. So I always like to tell patients, we want to get this thing released, and if there are nerve fibers on the border or on the fence, I want to get those back to us. Get that pain that you have at night and during the day and the shaking to go away. But then it's going to take some time to see how many of those nerve fibers will wake back up, because some of those, if they're permanently damaged, will not. And then they'll always have constant numbness and tingling. It's still a successful surgery, but unfortunately, those nerve fibers have already been damaged. We can't get those back.
The hand is amazing. Fixing the hand is amazing. I love hearing you talk about how great it is coming to work to be able to fix somebody's hand, wrist, elbow, something that's bothering them. Tim Renfree, thank you so much for coming to the Dr. Bob Show. You're a great teacher.
Thank you very much for having me. I appreciate that.
If you've got problems with your hand, know that it needs to be evaluated properly and the problem can be fixed. And now you're going to want to stay tuned. A lot of information for you. You'll be talking about psoriasis. Is it contagious? Is there new treatments for it? And the heartbeat. What happens when the heart thrusts blood out? Does it always do a good job? What keeps it from doing a good job? A lot of information for you. You'll want to stay tuned. I want to thank Dr. Tim Renfree. Wonderful discussion on orthopedic problems with the hand. Now for questions from you, the viewer, that I think will be important to your health. Question number one, Dr. Bob, I have a cousin with a diagnosis of psoriasis. It looks terrible. Is it contagious? And what should be done for it? Well, lots of good questions concerning psoriasis. Psoriasis is a skin lesion. It's the same frequency in men and women. About 2% of the population will get it. There's 5 or 6 different types of psoriasis, but the most common cause is a plaque psoriasis. And that's where there's a little round area that has red raised skin with a scaly, silvery scale front. Now it's interesting that what happens in these psoriasis lesions is there is an overproduction of skin. It's not that something happens to the skin, it's produced more and more rapidly than normal, some 10 to 50 times as frequent as normal. And it forms these little plaques. Sometimes they can be itchy, sometimes they can sting, sometimes they're dry. What is the treatment? Why do people get this? Number one, it's not contagious. We really don't know why people get this. But the treatment is frequently to keep that skin soft. So we start off right away by knowing that if we keep the skin soft with simple lotions, that it will help the lesion get quiet. We can put cortisone creams, anti-inflammation, that will help that get quiet. If that doesn't work, most of psoriasis lesions are treated by skin specialists, dermatologists. And the dermatologist can then begin to use different medicines. For instance, there is light therapy that can be used for people that have psoriasis. There are medications that can be taken that decrease the intensity of the lesions of psoriasis. Humira is one, Stelara is one. There are several different ones. And all of these biologics, all of these medications have to be guided by a professional. So know that if you have psoriasis, there is treatment available. It can be treated. It's not contagious, but it's something that can be treated and hopefully can go away. Question number 2, Dr. Bob, my doctor is talking about my heart is not throwing out the proper amounts of blood. What's the problem? Well, that's called ventricular ejection fraction, and it's predominantly left ventricular ejection fraction. The heart pump, the part that pumps the blood out to the body, is the left ventricle. It's got a chamber, it receives blood. It receives about 70 milliliters. That's a little over 2 ounces of blood. And with each heartbeat, it thrusts that blood out. Now, it can only thrust out 50, 60, 70% of that 70 milliliters. That's the ejection fraction. If the ejection fraction is between 55 and 70, it's normal. If it gets below 55, then there's not enough blood being pushed out to help support the nourishment of the body. If it gets less than 40, we're in heart failure, most likely. What can cause the heart not to push the blood out? Well, there's a couple of things. Number one, it could be that there's stiffness of the muscle, so it just doesn't beat efficiently. Number two, that muscle could be dilating and get weak where it doesn't work good enough to throw the blood out. So when your doctor measures your heart function, he'll frequently get a left ventricular ejection fraction that will help him know how good your heart is pumping. Well, that's all the time that we have for this show. Remember, those 4 things that we like to talk about on the Dr. Bob Show. Number 1 is exercise. Everything proves that exercise is probably the most important of all things that we can do. Exercise reduces stress. It will help us lose weight. It makes us function better, it makes us feel better, it makes us sleep better. So be sure that exercise is a part of your daily routine. Eating properly, we're marketed to eat food. So be sure that when you eat food that you're eating less and that you're eating proper foods. Most people know what good foods are and what they're not. If you're hungry, go ahead and eat, but be sure that you eat good food. 7.5 hours of sleep, oh, how better you'll be the next day. There are so many things that keep people from getting a good night's sleep. If you're not getting a good night's sleep, if you're not sleeping 7.5 hours, then be sure and talk with your doctor about that. And most of all, what is it we like on the Dr. Bob Show? It's that laughter in your life. You know, the more we laugh, the more fun life is, the more fun it is for people around you, and the healthier that you'll be.